You may start now.
Good evening, everyone. My name is Hetal Gohil and I represent the Medical Services Department of Hetero Healthcare. On behalf of Hetero Healthcare, I would like to welcome you all to this important webinar on managing long-term survivors of HIV, medical and social challenges. Before we proceed with the today's agenda, I would like to take a moment to briefly introduce Hetero Healthcare. Hetero is one of the world's largest producer of antiretrovirals APIs and has been strong partner with HIV experts across the globe. We mark 25 plus years of our journey in HIV management and catering to 40% of existing global demand of antiretrovirals and finished dosage forms. This was possible only due to strong R&D team and state-of-art manufacturing facilities that have ensured seamless supply of life-saving medicines. This journey wouldn't have been so impactful without your support and blessings. First observed in 2014, 5th June is a day to honor long-term survivors of HIV and raise awareness about their needs, issues, and journeys. HIV long-term survivors represent a diverse group of people, including people who are diagnosed with HIV before heart in 1996. They make up to 25% of all the people living with HIV and AIDS, as well as those people who acquired HIV at birth or as young children, also known as lifetime survivors of HIV. As we know that around 2.5 million people are living with HIV in India, marking a 44% decline in new HIV infections since 2010. Adult HIV prevalence is around 0.2% and estimated annual new HIV infections are around 66,400. Over the decades, the life expectancy of people with HIV has increased due to improved efficacy of the treatment. CDC has estimated that around 50% of people living with HIV are older than 50 years. By 2030, this number is going to rise to 70%. Yet, with aging comes new challenges, and by 2030, more than 80% will have at least one age-related medical condition, such as cancer or heart disease. The statistics highlight an urgent public health issue that demands immediate attention and sustained action. This year's theme, Leading with Legacy, which encourages long-term survivors to share their experiences, stories, and their journeys of overcoming social stigmas to educate and inspire others. Decades later, the narrative of HIV has been evolved from a period of fear and stigma to hope and progress. To explore these important topics in depth, it is my great honor to invite a pioneer in HIV care, Dr. Ishwar Gilada, to educate us on the topic of managing long-term survivors of HIV, medical and social challenges. Dr. Gilada is HIV, STD, and infectious disease consultant at Unison Medicare and Research Center, Mumbai. He is the honorary secretary of People's Health Organization India, and he is also the president emeritus of AIDS Society of India. He is the Secretary General of Organized Medicine Academic Guild and governing council member of International AIDS Society, Geneva since 2018. He is also the chairperson of Asia and Pacific region of IAS since 2024. He is also the member of Permanent Monitoring Panel for Infectious Disease and World Federation of Scientists Geneva since 2013. He has addressed more than 4,000 meetings and training programs in India and several HIV-burdened African countries. He has presented 324 scientific papers at conferences and in journals, and as well as book chapters. His tireless contributions have earned him 88 national and international awards, including Outstanding Young Person of the World at Glasgow, UK in 1995 and Anne Marine Medicine Award, Munich in 1999, termed as Indian Machine Gun Against AIDS. Welcome, Dr. Gilada, sir. We are honored to have you with us. Now, it is my pleasure to welcome our esteemed panelist, Ms. Daxa Patel, ma'am. She is prominent HIV/AIDS activist from Gujarat, India, and founding member of the National Coalition of People Living with India. She has been instrumental in advocating for the rights and well-being of individuals living with HIV/AIDS. Her journey began in 2002 through community mobilization and collaboration with the civil society organizations, the government, political leaders, bilateral organizations, and corporate partners in Gujarat to convene a local to national dialogue aimed at revitalizing civil society advocacy efforts in fight against HIV and AIDS. Her dedication to reducing HIV-related stigma and discrimination is further exemplified by her founding role in Gujarat State Network of People Living with HIV and AIDS. She has been instrumental in promoting the formation of mixed self-help groups to foster inclusivity and support sustained care support model in partnership with Government of Gujarat, public-private partnerships, and other donors. Welcome, Ms. Patel, ma'am. We are privileged to have your voice and insight with us today. With this, I would like to hand over the session to Dr. Ishwar Gilada, sir, to begin the discussion. Over to you, sir. And I thank you, everyone who has joined us today. Thank you. Sir, you can proceed, sir.
Uh, Thank you very much for Hetal for introducing me. Today is a really great day, not because it is my official birthday, because it's my passport birthday. My real birthday is 29 December. And today you have chosen a theme in such a way that all four entities have spent more than 25 years in the field of HIV. Whether it's Daksha living with HIV for more than 25 years, Hetero Healthcare for more than 25 years, my clinic, Unison Medicare, more than 30 years, and I've been in this field for more than 40 years. Are you able to see second slide?
Yes, sir.
Okay. So basically, when we talk about long-term survivor, I'm reminded of one thing. About 30 years before, when my daughter Trupti, she spotted one white hair in my hair, and he said, "Papa, white hair." And just a couple of days before, my grandchild, he spotted a black hair in my beard. He said, "Nano, there's a black hair." So this is 3 decades. And when we talk about that, there's a lot of, it's not only aging, it is a lot of experiencing. We have learned a lot of things from PL HIV, including Daksha. So we are in day-to-day learning. When we define who are long-term survivors, they are doctors, other healthcare personnel caring for PL HIV as long-term commitment. Pharmaceutical companies, especially those making ARVs and including hetero. PLHIV is on ART or without ART. A lot of people do not know about ART, therefore I am specifying. And for decades, those who have lived with HIV for many years are often called long-term survivors. LTS refers to those who have been living with HIV since before the modern era of effective HIV drugs or highly active antiretroviral therapy, which is called HART. That is before 1996. Long-term non-progressors, both elite and viremic controllers, they can live without ART for years. And this is a presentation which we have given at Munich, where we didn't know that we had a very large pool of people living with HIV without ART for more than 35, 30 years. And after this presentation, Dr. Paul Sachs and Dr. Steve Dix, a pioneer from San Francisco, they came and visited us and they said, "You are one of the largest pool of elite controllers, those who are having control HIV but without ART." Now, what happens when a person comes? Because Hital has given a lot of statistics, but we doctors, we don't live with statistics. We live with real patients. Now, what happens? A patient comes to us. Patient comes with a lot of thoughts in mind. Should I have children? What will happen to my marriage? Should I divorce? Should I continue my job? Should I use condom? Should I approach my wife? Sometimes people, even from before entering the bedroom, they call me in the midnight. Doctor, really, can I enter bedroom? And that kind of situation we needed to handle. And when a person is informed, it is counselor and the doctor, they have to satisfy each and every question of that person. We cannot expect the person is divided into kind of spare parts and refer to different doctors. Now, when we talk about milestone, our first HIV infections in India were in 1986 in Mumbai, in Chennai. In Mumbai, they were in sex worker, and one of them was Hijra. First AIDS case was in Mumbai, that was at Jaslok Hospital. First AIDS clinic was established at JJ Hospital by me in 86. 89, we had made blood screening compulsory in Maharashtra only after PHO filed a public interest litigation in High Court. That time it was not called PIL. It was a criminal writ petition in High Court. In 1991, first HIV 2 cases were reported. 1992, NACP, National AIDS Control Program, was launched, which was 7 years after PHO started HIV awareness. AIDS Wadia Safe Motherhood project started at that time. 1998, HIV test made mandatory all over the country after Supreme Court gave a guideline. And it took 9 years from High Court of Mumbai to Supreme Court. 2001 PMTCT program launched, which was 9 years after PHO started Wadia model. In 2004, free ART rollout started, which was 9 years after private sector started ART. 2010, free second line ART added in the program. 2019, test and treat, provision of third line, viral load in public-private partnership started. 2020, DTG, dolutegravir based regimen started in program, and in private sector we started in 2017. 2024, discussion on quality of life started, but yet to take a shape. And 2025, in private sector, we are moving to manage patient on 2-drug regimen, which is yet not in the program. So when we talk about HIV and all the years, I have divided my talk into 5-6 different departments or sections. Changing trends in the age of population, consideration before starting ART in test and treat era, because when you say test and treat, that doesn't mean that as soon as you see a patient, start shooting. So what are the considerations? Managing age-related non-HIV comorbidities, there are diabetes mellitus, cardiovascular diseases, osteoporosis, renal diseases, hypertension, non-AIDS malignancies, mental health, sexual health, and frailty. Then adult vaccination, holistic care and celebration. Celebration is very important because earlier it was a ghastly scenario. People were dying in numbers and numbers. And conclusion and take-home message. So when we talk about HIV, what happens is the graph, which is of CD4 count, is start going down, and the graph, which is of viral load, is start going up. And there's one time comes when they cross each other, and that's a point of decline. Earlier in the pre-test and treat era, we used to wait for this kind of graph to cross each other, wait for the oral thrust to appear, and then decide to start ART. So when the CD4 start going down, then the one or the other symptoms start coming up, and the dividing line between at 200 CD4 count being the oral thrush. And then when it goes down below 100, when it goes down below 50, then more and more complications are added. Particularly below 100, you get complications in the eyes and brain. And eyes, there could be CME retinitis, where the person can become blind, cortical spot, always colored halos when a person is walking or talking. And in CNS involvement, that can be toxoplasma, tuberculosis, cryptococcal meningitis. So when we talk about treatment failure, because most of the people are on treatment now. So treatment failure can be in 3 ways. It can be virological failure, which happens first. Second is immunological failure, where the CD4 counts are rebounding or going down despite treatment. And third is clinical failure. So if we wait for a clinical failure, then we lose crucial 2 to 3 years time. And therefore, based on viral load, we decide immediately that person is, if undetectable viral load, fine. If the viral load is bouncing back, then we need to monitor at least one more time and give a chance to the person for adherence, etc. If it doesn't improve, we need to change medicine. Now, all these algorithms started when we were haves and have-nots. When only Western countries had a lot of exposure to ART, and we were in the have-not category. And at that time, in 1995-96, hardly 2 to 5% people could afford ART, and another 2 to 3% could afford based on somebody supporting as a one-way traffic that okay, I will give you money. And that time, our goal was that okay, make your girl 10 standard, or make an engagement happen. So we are buying time for 6 months, 1 year, 2 year. And just like in a government 5 year program, we used to tell people that you make your 5 year plan and come back after 5 year, we'll decide. And after 5 years, patient come back, sir, 5 saal to ho gaye. Then another 5 year plan. So that time, the guidelines with the WHO or guidelines with UNAIDS were changing every 4 5 years. But in 2016, the guideline changed 4 times, and then it started test and treat. That they said there's no need of monitoring viral load, no need of monitoring CD4, no need of waiting. As soon as you test person positive, start ART. And most importantly, that time the very potent drug came, which is dolutegravir. So now onwards, there is only no role of CD4 for deciding to start ART, but role of CD4 is always there to monitor HIV patients or PLHIV. Now, this is a slide of 2013. At that time, when they compared after few years of ART, what has happened? Almost 20 years of ART. What has happened? When the average lifespan in US was 79 years, and currently it is 82 years. And in India, that time it was around 68, 69, now it is 71 years. So we used to think that, okay, HIV positive person lives 4 5 years less than non-HIV. But now they are equal to non-HIV. And sometimes I believe that they live better than non-HIV because they are always constantly under care, under surveillance, under adherence, under any other diagnosis which non-HIV people do not have. So what happens is when we talk about comorbidities, we talk about 4 5 main organs. It's not their body has several organs, several parts and spare parts, but what can be affected? Kidney can be affected, bones can be affected, heart can be affected, brain can be affected. And when we talk about the aging population, when we take up statistics of the National AIDS Control Organization, now they are also seeing that more people with HIV are going beyond 50 years of age. And that was benchmark at that time, though we used to call 58 or 60 age of retirement for non-HIV. And for HIV, 50-year age crossing was a big deal. And then we talked about the risk of the aging. What can happen? A patient can be individual risk, gender, because of gender, male, female. There are always disparities. Genetics, hypogonadism, menopause. It can be higher rate of traditional risk factors. It can be smoking, dyslipidemia, hypertension, and diabetes. It can be obesity, diet, and physical inactivity, poor engagement in care, and poverty. Poverty plays role everywhere, whether you talk A disease, B disease, or C disease. And then the virus we call host-parasite environment relationship. So virus is parasite or organism. There is a HIV infection itself, inflammation and immune activation or reactivation, co-infections, and late diagnosis. And treatment, it can be ART and toxicity, it can be a drug-drug interaction, and all these lead to either diabetes mellitus or cardiovascular disease or non-AIDS malignancies or renal problem or hypertension and osteoporosis. So when we go to managing these issues, we talk about glucose and insulin metabolism. If we compare HIV and non-HIV, the risk is double in HIV positive person. Prevalence of impaired glucose intolerance is around 9% in diabetics and 18 to 35% in HIV positive people. HbA1c, which is the marker of 3 months of average of sugar, which goes haywire in people living with HIV. So if you look at the graph, you'll find that in HIV positive and in control people are below the graph, below the blue graph, and more and more HIV positive people are above the graph. So what is important is screening and management of diabetes. So how fasting glucose has to be seen. If 100 and 125, consider post meal. or GTT, that is a glucose tolerance test. Look at HbA1c. Normally it should be 5.6, but if it is more than 6.5, then you should be alarmed. Fasting glucose every 6 to 12 months. Consider testing 1 to 3 months after starting the modifying ART, and which is some of the common culprits are lopinavir, ritonavir, and now DTG. How to manage individualized in key is a key. Goal for prevention of complication is the HbA1c should be always below 7. So when we look at chart and look at what can happen and drug-drug interaction, the safest drug has been raltegravir, but raltegravir is number one, expensive. Number two, you have to take 2 tablets of raltegravir, and number three, it is not available as a combination. So second best has been DTG, where there is a problem with metformin combination. When you give, so you cannot give more than 1 gram of metformin when you are giving DTG. Otherwise, the safer drugs on the right side, they are abacavir, FTC, 3TC, TAF, TDF, and zidovudine. So we also look at the cardiovascular risk factor. There are cardiovascular risk factors in people with HIV that can be age, sex, smoking, blood pressure, weight. If it's obese, there are more problems, lipid, glucose, and renal, and they can form atheroma, and atheroma will create a problem, and that can lead into a lot of cardiovascular problems. It can be plaque formation, it can be thrombosis, and ART also can lead to this kind of activity. HIV also can lead to this kind of activity inside the body. So our job is to stop inflammation, atheroma formation and growth, plaque inactivity, instability and rupture, and thrombosis. Then we have to also look at metabolism syndrome, or a lot of metabolisms which are haywire. It can be visceral, that is in the organs. It can be insulin resistance. It can be hypertension. It can be low HDL cholesterol, and it can be high triglyceride, which are also there because of the ART. Now we have to also look at how do we manage. Lifestyle modification is very important in every part of the management. Check if any medications are increasing the risk of this. Pharmacological therapy, there has to be lipid safe ART. Lipid lowering therapy should be given if at all you need to give. And if the lipids are already high, management of metabolic syndrome, diabetes, and metformin. And consider avoiding abacavir in patients at related elevated risk of cardiovascular disease. So when we look at that, then TDF and TAF, they are the lowest risk, and all other this side, they keep on increasing the risk of lipid issues. Then we have to look at bone. Bone mineral density is important, osteopenia, osteoporosis, and fractures, and sometimes avascular necrosis, which is basically causing fractured neck of the femur, and the person has to be bedridden for life. So we need to look at again the issue of what is patient, what is virus doing, what is the treatment doing, and most of the issues are the same except vitamin D deficiency, which is playing a major role in the bone metabolism. Again, there is a 6 to 7 times more chances of getting osteoporosis in people living with HIV than non-HIV. Again, management is lifestyle modification and vitamin D supplementation. So if you are not able to do vitamin D test often, then it is wiser to give vitamin D supplement once a week for 8 weeks every 6 months. Now, when you give vitamin D3 supplement, it requires calcium for metabolism, and it can take away your body calcium. So during that period, you need to supplement the body with the calcium. So you give, say, for example, 8 weeks of 1 weekly therapy of vitamin D3, then you add 60 days of calcium. Safer for bone, and what are the safer for bone is TDF and if TDF is there, it is not safe, so we need to shift to ABC or we shift to TAF. And I'll explain to you 300 is equal to 25 how it works. And PI, if patient is on PI, shift to DTG. Then there's the role of biphosphonates, alendronide and zoledronic acid, and they are little expensive. Then there are renal complications. Renal complications can be because of BMI, because of smoking, because of hypertension, because of age, and because of diabetes. And often people don't have one problem, they have 2 or 3 problems. So it leads to the HIVON, or which is HIV associated nephropathy, which can be drug induced. So sometimes person comes and asks, where is my kidney? Kidney is gone. This is a chronic renal failure, chronic renal disease. And we need to keep monitoring, and we need to really monitor if the person is on the TDF based regimen. So when we talk about tenofovir versus TAF, tenofovir alafenamide. So rather than 300 milligram of tenofovir, even if you give TAF 25 milligram, that is equivalent to that. It will work almost the same on HIV, but it will do 1/12, 11/12 less harm. That is almost 80-90% less harm on HIV positive person because of the tenofovir. And on after some time, if the person is virally suppressed, say after 2 or 3 monitoring, then you can remove TAF, you can remove TDF, you can put person on the 2-drug regimen. So often for a doctor, it has been a balancing act. So what is so bad about 2 NRTIs and plus third drug anyway? So we need to balance whether kidney and bone is important, whether heart is important. And for us, both are important. So we need to really monitor depending on what drugs we are giving. And we need to look at monitor the kind of chronic kidney diseases based on serum creatinine that need to be seen every 6 months minimum, and also urine proteinuria. If protein is going on in the urine, then we need to look at that. So as the person is growing, that person will also catch the problem which any HIV negative person also has. And then we need to look at cancers. Cancer can be cervical cancer, breast cancer, both are in female, and screening of oral cancer. In male, we need to keep on examining mouth because sometimes they can get oral cancers. Then there are mental health issues. Mental health issues can be because of stigma, because of rejection in the family, because of rejection in workplace. Somebody is removed from job or given a different kind of job, or some stigma is created at job, so person leaves. Financial insecurity, dependence, fear of disease, and fear of death. So everybody has a fear of death, but with HIV positive people, they have more fear of death. And sometimes they keep on asking, sir, or kitne saal hai? So over 50 to 70% of our 75% of our study group of older adults with HIV showed depression. The depression initially could have been because of efavirenz, but still there are depression, and some depressions are common causes in HIV positive or negative, but some are definitely associated with HIV and the treatment they are taking. Causes of non-adherence to all medication, including ARV, and that increases in suicide rate also. So when in a private setup, when in any kind of clinical setup, we need to have a non-judgmental approach, because the problem can be in HIV, problem can be in homosexual, heterosexual, bisexual, or anybody. And here the fever is fever, problem is a problem, infection is infection. We need to look at in a totally non-judgmental way, and therefore we need to have our clinical setting in such a way that nobody is ill-treated in the setting. Now, what is happening as the age with HIV is increasing, people are living longer, and they will continue to have sex whether we like or we don't like, and they sometimes can also go on the apps like Tinder, Grinder app, etc., to pick up their partners. So, despite whatever counseling we have done all along, there are people who are engaging in casual sex activity. Now, to just describe a casual sex activity, and they are changing rules in sexuality. Here, I think if you observe properly, what is dog doing? Is Bill Clinton, and Hillary is saying, Bill, let us call her Monica Lewinsky. So everybody in the world knew what was Monica Lewinsky for Bill Clinton. But we, as a HIV practitioners or in the field of sexuality, we grab that particular headline where Clinton never had a penetrative sex with Monica. It was always oral sex. So when we look at that, what kind of sex are available? Hugging, kissing, smooching, masturbation, self and mutual, using vibrators, using e-sex, non-penetrative sex, memory sex. One of the patients said, sir, I had memory sex. I thought he is just memorizing sex. And I asked him, what is memory sex? So he said, I had sex between breast, and that is memory sex. And I had also spotted a primary chancre, which is a type of syphilis on mammary gland. Live-in relationship, bisexuality, orogenital, where they call 69 position, sex with unknown partners, and by design, they go on weekends with using dating app. Sometimes they go couple swapping, orgies, and chem sex. Chem sex is not in Gujarat. my friend Daksha, where they say chemsex, sexuagini. It's a chemical and then sex. So a lot of people, young people, are opting for chemical and sex. And most doctors advise avoid sex. So we need to look at that. Is it practical and is it possible? So I think I will be able to play this video, which shows changing trend of sexuality. Let me see if I am successful. I think sound quality is not there. So let us go to the next slide. So now we go to prevention of opportunistic infection. For tuberculosis, earlier it was every 2 years we used to give isoniazid 300 milligram every day for 6 months. Now that has been shifted to 12 HP, that is INH rifampicin combination once a week for 12 weeks or daily for 30 days. So currently in program, NACO program, they're using 30 days INH and rifampicin. And this has to be given only once in lifetime if adherence on ART is maintained. PCP prophylaxis less than 200 CD4 count, cotrimoxazole 1 DS tablet daily. In some people, we can also give half because sometimes they get acidity. Toxoplasma less than 100 cotrimoxazole 1 tablet daily. But all other like cryptococcal meningitis, MAC, Candida, or CME, prophylaxis is not indicated. Now, this is one of the patient who was admitted for a very simple diarrhea and which I diagnosed that as only allergic diarrhea. I given one levocetirizine and diarrhea stopped. But the patient was given so many medicines, you can imagine. So if you are giving so many medicine and Virade is also there because of HIV, so you can imagine how many drug combination can be there. And you can see I stopped all these drugs, continued only on these three drugs for some time, and then put the patient on a dolutegravir or other regimen, which is. Then we talk about adult vaccination. Vaccination till COVID has been always in mind of people that is only for children. But we have been doing adult vaccination since 2010. Now it has become very popular, and there are some vaccines which should be given to everybody. Hepatitis B, which is 50 to 100 times more transmissible than HIV. Hepatitis B is tested at all the levels, in all blood banks, in all ART clinics, in all pregnancy clinics, but we don't advise that those who are hepatitis B negative should be taking vaccine. It's a peanut costing vaccine. 3 doses will prevent hepatitis B for entire life. Pneumococcal vaccine once in lifetime. HPV vaccine, those who are really sexually active and having multiple partners, they should take. Earlier it was advised only for female, but female get HPV from males only. So it has to be male, female both. Typhoid once in 3 years. Influenza vaccine, a seasonal vaccine, so we need to give every year. And varicella zoster, which is a very expensive vaccine, but those who can afford, they should take. And pediatric immunization program should go on as it is going on in HIV negative people. We talk about holistic care and celebration. See, beyond age, we need to look at some issues like we need to ask people to stop addiction. If not possible to stop, reduce it. Healthy lifestyle, exercise, yoga. Sometimes we ask people, are you doing exercise? हाँ कभी कभी कर लेता हूँ. So कभी कभी कर लेता हूँ is a time pass. Exercise means a daily. Positive thinking, nutrition, involve family members, caregivers. It is not compulsory that they should involve family members if the person doesn't want to. But if involved, then it is better for mental support and family support. Caregiver or support groups. Advice to help others and it will come back to you. Mental health and sexual health. Avoiding multiple health visits. So comprehensive health care. So we don't have to have a different visit for hypertension, different visit for diabetes, different for HIV. At one place, everything should be done. Easy prescriptions and adherence to medicines. Open-ended questions. Advice to avoid polypharmacy, polypathy, and window shopping. People keep on going to different places. And remember, HIV phobia is a bigger problem than HIV. And Google disease is the biggest problem, which has no treatment. Then very important that we need to stop discrimination. Discrimination is reduced, but it has not gone away. Discrimination is still there of different level, different cadre. And I remember at a time, the case clipping is of 1990 or 1989. People with HIV from any department, they were pushed to skin department, whether it's a neurology patient or delivery of somebody or a child. And we were managing in skin department, but apart from managing, we are trying to train those doctors from different specialty to come and see how, despite I'm not being obstetric and gynecologist, I delivered a lady there. So I said, you are expert, you should do, and people are done. And therefore, today JJ has become a model of care in the HIV era. We need to walk 1 mile extra, and that is like positive weddings. Positive negative weddings are happening more now. Alliances happening more. So though we initially started only positive marriages, now couple comes, they have a counseling. They say that if undetectable is untransmittable, we would like to go ahead. And today we are having more positive negative alliances than positive alliances. We used to have that 15 years AIDS Asia, which was the only of its kind in the entire Asia, and we used to publish that and distribute. Then having a kind of a music show, and the theme was "Ye Jeevan Hai." Ye Jeevan Hai is Jeevan ka yahi hai rangroom. And on the same desk, we have HIV positive people, HIV caregivers, musicians, pharmaceutical companies, society, family members. No one can make out who is positive. Now, for last 1.5 years, 2 years, we started those people, those patients who are with us for more than 25 years. We cut their cake at our cost. We call all our staff, and a patient gives his or her suffering or whatever, how the person has come up. And then it is a good feeling for those which are young people, which are coming for the first time. Now, how things have changed? Because I always say to the practitioners as well as HIV positive patients which are diagnosed now, that you are in a very good era. For a HIV positive person, you get simple one medicine and just take a medicine and sleep. Much better than diabetes. For a HIV expert or a doctor caring for HIV, very easy treatment. During those days, Zidovudine was available with only one company, and they were not able to give. We used to send a doctor from our clinic with a patient. Patient didn't want to give name. Doctor used to get medicine in his name from that godown. So that is the era when people used to take almost 20 medicine at a time. And then it started with 4, then 2, then 3 compliance pack, then 1. And then after 1, patient used to come, sir, gale mein medicine nahi jati hai, atak jati hai. And then we ask for a smaller medicine. Now the smaller pills are there. Now bi-monthly injectables have come. 4 companies have been licensed to make that. It is yet to come in market, but it's a great hope that you don't have to take a pill. You just come in once in 2 months. Another trial is going on for once in 6 months. And that can happen. And initially we were beggars. After that, we were getting so many medicine. Now simple medicine, one medicine. So sometimes we used to have a thinking that more medicine will act more. It's not so. So here, less is also more. Lesser dose, lesser pills, lesser pill size, lesser toxicity, like DDI, lesser susceptibility to resistance, and lesser dose. So when we look at that, efavirenz 400 versus 600, TAF 25 versus TDF 300, DDI 400 versus 250, D40 40 versus 30. D40 now is out, hardly anybody is using. Zidovudine 600 versus 400. Indinavir 800 versus 400 BD, and that is also out now. Darunavir 600 plus 100 was BD, now it is 800 plus 100 OD. And 2-drug regimen, where a lot of people can be put on 2-drug regimen. Now feature could be that DTG can be 25 milligram, because when initial trial was there, it was 10 milligram, 25 milligram, 50 milligram. And the results in 25 and 50 were similar, but somehow it was chosen to have 50 milligram. And similarly, bictegravir. So now, if you talk about 3-drug regimen, bictegravir based regimen, combination of 3, doravirine based regimen, darunavir based regimen. Then it can be 2-drug regimen. Again, it can be dolutegravir and rilpivirine, or dolutegravir and 3DC. How DTG 3DC affect first line ART options? So there are advantages and disadvantages, and you can always be advantageous to have one drug less, one toxicity less than the three one. What do people with HIV expect? They expect that medicine should be low cost, single tablet, smaller medicine, no food restriction, good survival, smaller pill size, no physiological pathological restrictions, no new disease condition, and build up and maintain good immunity. What do we physician expect? We also want a better life. We don't want to get up in the night. So we want less emergencies. We want, in any case, physician do not want to lose their patient. So our patients should survive. No emergencies, no ADRs, new molecules and come all the time. Otherwise, it will be like a pharmacy giving a medicine. To remain consistent in approach, rapid turnaround time. People have no time, whether they are PLHIV or doctors who need to have a quick turnaround time, ease in diagnosing, monitoring comorbidities, and when people living with HIV is on co-medication, mechanism of age-related monitoring has to be there. Then what is the strength of private practitioners? We are non-judgmental. We are non-discriminatory in approach. We have long-term rapport. We have rapport with 25, 30, 34, 32 years with the patient. So we provide pediatric to geriatric. Some children are born before us. They are now 30 and they can live another 25 years. So we call cradle to grave care. Knowledge with the specialized team, often abreast with the current developments, open to quick adaptations, can be after this talk, and they don't need a circular from government. Adverse effects and co-infection management, welfare of patient, which is most important for us, and point of care and rapid turnaround time. New and bold initiatives, innovation transgressing into practice. And for example, some of our innovations are 3-in-1 combo, was suggested by us, made by a pharma company. Now it is a present day practice. ARV dose reduction, efavirenz 400, we suggested. Now it is of 400 as a standard of care. Avoiding second DTG pill for TB patient as a co-medication. There is no need of giving two DTG, and people are working fine. Virally suppressed and TB is also doing well. All different combos available, so quick correction and switch possible with private practitioners. So basically, when we talk about ARV regimen, it is like 4C: cap, cloth, condom, and chappal. They have to be of different size. One size doesn't fit everybody. Now coming to the discrimination. If you recall this 1989 press clipping, we started a movement in Goa where the Dominic D'Souza was jailed in Goa, and after 2-3 months of fight, that person was out. And at the same time, we introduced a bill in Parliament through a private member's bill. You can see that 1989 is a letter from the Parliament of India to me. And now it took so many years' time, and now Dominic D'Souza was freed. Discrimination still goes on, and my brother Nikhil was made on Dominic's life. So this HIV/AIDS Act 2017, though it has been passed in 2017, it was hibernating for 30 years, 28 years. And despite this, in last 7 years, 8 years, there is not a single prosecution. That doesn't mean that violations are not happening. There are no people to file complaints. There are no people to fight. Here, there is a very good law to fight against the insurance companies, against hospitals, against doctors, if you are discriminated. So what are the major problems still remains, need to be solved? Most doctors are not interested in HIV management. Most of our dermatologist colleagues who were in HIV practice, they have become cosmetologists. So because HIV, there is not much money. Lack of trained and committed workforce for ART centers. So they are like a parking lot. They keep on rotating every 6-8 months. Test and treat has its challenges. CD4 still remains important. So apart from viral load monitoring, CD4 should be monitored. Managing OI and co-infections, metabolic disorders, advanced HIV disease. MDR HIV, MDR TB, XDR TB, XDR HIV. So there are patients where there are a lot of resistance testing is required, and that is in scarce. Iris, sometimes more fatal than the disease condition. PLHIV marriages which are happening but should happen more. Changing pattern of sexuality we need to keep in mind. Discrimination should stop, and the law should be used very effectively, and dose reduction and true drug ART should be part of even NACO program. Immunological failure, immunosenescence, despite doing all these things, CD4 count remains below 200, and we need to keep monitoring because they are also aging. Lipoatrophy and lipodystrophy, the best thing to happen in India is NACO is self-sufficient. It runs a program on its own state exchequer and is least affected by Trump's decision to onslaught PEPFAR, USAID or NIH. So I think that was a cause for celebration when the Trump was having a kind of a high attitude to stop this medicine free of charge. India can step in, and in the global scenario, India is the only country which can come to the rescue of Africa. Now, just to give you examples of immunosenescence, patient started with CD4 6, 24, 44, 87, 112, it's stuck there. Viral load suppressed, but CD4 is not going up. So there are people who will not respond immunologically, and we need to keep them in mind also, and that can be done only because of CD4 monitoring. Then buffalo hump, people with D40, lipoatrophy, lipodystrophy, they look aged, though they are not, and we still don't have good answers. And U is equal to E is very important. We should propagate that. There is no difference between HIV positive and HIV negative once the person is on treatment for more than 2 months. And now the shifting focus is prevention is the only treatment. Earlier it was prevention is the only treatment. Now is a treatment as prevention, and we have shifted our focus. This is our clinic which started in 1995 in Mumbai, Unison Medicare. Now 30-year-old, we are celebrating 3 decades here this time. And the Unison has everything under one roof, and we have our quickest turnaround time. We can boast that we are globally quickest turnaround time. Within 3 hours, everything can be done, including viral load, CD4, sonography, X-ray, investigations, and treatment. And what is how wish list has modified? In 1980s, it was a mere death sentence. Deaths made headlines. First death, second death, Maharashtra's second death. Then it was blame game. Who should be blamed? In one death, I was blamed because government said because of him the patient died. But the patient died of tuberculosis, and they were not willing to accept tuberculosis. Often we used to do a terminator counseling. We used to tell family that ये मरने वाला है, इसका अरेंजमेंट करो, म्यूजिक लगाओ, भजन लगाओ, इसका लास्ट इच्छा पूरा करो. 1990s, give us few days. Let me put my house in order. Attend event. We started telling them make 5-year plan. In 2000, ART prolonged lives, prevented deaths, prevented infections, and hope got more wheels. 2010, marriages, restarting sex, having child's marriage, normalization of pandemic, and confidence grown. And to 2020 now, quality of life is very important. Can I see my grandchildren's marriages? HIV is better than diabetes. So what has happened? I'll give you one story of one of my patient. My patient, who is under my care for almost 23, 24 years, had 21-year-old boy who died in accident. And parents came, and they were so, because after that they didn't have second child because of HIV. And they asked me what to do. I said, if you are still masturbating, you can still have a child. And they literally followed. And after 1 year, they came with a child. So I think there is no hope lost. Despite all whatever has happened in the life, life can still go on. Now, what I can always say to any new HIV positive person coming to my clinic, I tell them you get a full life. So your life expectancy at birth, which is guaranteed for 71 for male, 73 for female, is given to every HIV positive person. No HIV related hospitalization. You can be hospitalized because of accident, cancer, etc., but not because of HIV. No HIV transmission to spouse or to child. Can marry both positive and positive negative, and can have baby, and that too HIV uninfected. So this we can guarantee. And today there's a great hope which has come while I was searching, and I realized that I must speak that there is a chance of even finding a cure for HIV. This is Australian research where the medicine will act on DNA in such a way that DNA will never be active again, and the person doesn't have to take any medicine. So what is important? Helping age. Look beyond what you see, widen our management focus. While lifestyle changes remain the most important pillar, consider statins, biphosphates, bisphosphonates when needed. Strengthen the screening strategies. one-stop shop as far as possible. Avoid polypharmacy, polypathy, hybrid pathy, taking Ayurveda, Siddha, Unani, and allopathy. From optimizing heart can shift to two-drug regimen. One size fits all doesn't work everywhere. Adult vaccine as per requirement and affordability. Listen, normalize situation, focus on quality of life. And this slogan of PHO 2003, my friend with AIDS is still my friend, and that is still needs to be popularized. And I have AIDS, please hug me. I can't make you sick. This is a US poster, also need to be popularized. Now, I would like to thank you. I would like to thank Hitro and for your rapt attention. And at one point of time in 1985, I was on a crossroad. So it is a saying by Robert Frost, two road diverge in a wood, and I took the one less traveled by, and that has made all the difference. Now, when I'm also aging, as I told you, so I must have succession plan, and I'm thankful that my both the daughters are in the field of HIV and infectious disease. Trupti is a infectious disease expert, and Prapti is a microbiologist. And there is a saying in our community, Marwadi community, where one Shethji was retiring and called Munimji and asked Munimji, you take 2 months off and check all our property and see how much it is. So Munim said, Shethji, we have so much of property, it will take long time. Why do you want to do that? No, you take 3 month time. And Munimji spent 3 month time and came back laughing. And Munimji said, why are you laughing? Shethji, we have so much of property that our 7 generations will be happy and they will be all settled. But Shethji was not happy. So Munimji asked Shethji, why are you not happy? Are Murak, you are thinking of only 7 generation. Why are you not thinking of 8 generation? And therefore, I'm also thinking of the next generation. These are all my 4 grandchildren. When they come to clinic, in my presence or in my absence, the first toy they get is a stethoscope, pulse oximeter, and they enjoy. I don't know how many of them will be doctors, but at least one of them will definitely turn to be doctors. So for those PLHIV who are young now and they see me as an aging doctor, they can have hope in my daughter and granddaughters who will care them. Thank you very much.
Thank you very much, sir, for the wonderful talk and great insights. We have few questions, starting with you, sir.
Yeah.
So the first question is, how has the epidemiology of HIV in India has evolved over the last decade, last 10 years or 20 years?
You see, if you look at our HIV growth rate, which was going up and up, but it started going down. We are seeing 70% less infections than it was. And it was going down continuously, but in last 3-4 years, started going up again. If you look at the HIV map of India or graph, it was stuck at 2.3, 2.37, 2. Never 2.4. Now they're talking about 2.5. And possibly it is little higher than that. This is because of two things. Number one, lockdown can be always blamed. If you don't work, then you say lockdown. But number two, we neglected our prevention campaign. We neglected intervention campaign. For last 5 to 6 years, the NGOs which were working with the communities in the high risk areas or those which are key populations, they are not getting any funding because priority is not there for them. And there's no international funding, there's no domestic funding, and in a country like India, only deaths make a headline. If the people are dying, it becomes headline. Otherwise, HIV is no headline, is no priority. There was a time when TB was less priority than HIV. Now today, TB has more priority than HIV, and we need to piggyback each other because both of them coexist. So I think the NACO has to do 2 or 3 important things. Number one, start supporting NGOs which are working with the grassroots. Number two, start home-based testing, which is a HIV self-test. And number three, start PrEP and PEP. Otherwise, you are allowing people to get HIV, care them for whole life, give them free medication, free viral load, but you don't want to prevent by giving a free PrEP service. So I think these are the couple of things which need to be done to stop that kind of growth which is going on.
Okay, okay, sir. The next question is for Daksha Patel, ma'am, actually. So this is some stigma related question. Ma'am, what kind of impact does the stigma have on someone's well-being, even years after their diagnosis of HIV?
Yes, so if we will discuss about the stigma, तो स्टिग्मा अभी भी हम ऐसा नहीं बोल सकते कि बिल्कुल खत्म हो गया है. स्टिग्मा इज स्टिल अलाइव. जहाँ पे हम एचआईवी की बात करते हैं, लेकिन ये बात अलग है कि वो कहीं एक प्रैक्टिस में कहीं पे दिखता है, कहीं पे इन प्रैक्टिकल दिखता है. अ, लेकिन स्टिग्मा रिपोर्टिंग होना भी जरूरी है. और सेकेंडली मैं यहाँ पे कुछ एक्सपीरियंस भी शेयर करूंगी कि अगर मैं कहीं पे जॉब कर रही हूँ और वहाँ पे अगर मैं कॉम्पिटिट हूँ, फिर भी अगर मुझे प्रमोशन नहीं दिया जा रहा है, एंड इट मतलब मैं जो काम कर कर के जा रही हूँ और कंटिन्यू उसी जॉब पे मैं कंटिन्यू सेम पोजीशन पे हूँ, लेकिन मेरा प्रमोशन नहीं हो रहा है, बट द ऑनर इज नोइंग अबाउट माय एचआईवी स्टेटस or shifting me on other tasks as a tag of the giving the promotion. So that is the hidden stigma we can say कि जो directly नहीं लेकिन indirectly stigmatize किया जा रहा है. अभी भी जैसे हमारे एक्सपीरियंस में जैसे हम देख रहे हैं कि कभी कोई ऑपरेशन, बेसिकली हेल्थ केयर में ज्यादा हमें यही केसेस हम देखते हैं कि जहाँ पे जैसे ऑपरेशन है या कुछ मेजर इंजरी के लिए ट्रीटमेंट है, लॉन्ग टर्म ट्रीटमेंट है, तो उसमें डिनाइल और या डिले ऑफ ट्रीटमेंट, दैट इज अ काइंड ऑफ स्टिग्मा वी आर स्टिल getting reported through individual and community member or their families.
Okay, ma'am. Okay, thank you, ma'am. There is one question which has come up for Dr. Gilada. So, what can we do to better ensure U equals U and is reality for everyone?
See, for U is equal to U, number one, do a good baseline. Number two, that we always say in practice that if you spend good time with the first time, for the first time, you don't have to spend time each time. So spend good time, importance of adherence, importance of long-term surviving, and building a confidence mechanism. Because most important, when they come, they are shocked. Even today, a new patient comes, is always shocked, despite all information is available, everything is available. So give them a good confidence. Start a good medication which will suit that person. If the person is having some issues related to mental problem, then you don't give a medicine which will trigger that. If person is already having a diabetes, then try to avoid the DTG based regimen. Give another regimen, because you don't want to trigger. Later on you can switch off, but initially you want to give a good treatment, and ask the person to come back after 2 months, whether DTG based regimen or beta based regimen. Within 6 weeks to 2 months, they are undetectable. Now, some people will say, why 2 months? You can wait for 6 months. At ART center, they will do after 6 months. But in confidence building mechanism, when the person has come with a lot of negative thoughts, after 2 months, you show the result that weight gain 5 to 10 kg, viral load is suppressed, CD4 has gone up, no other concomitant diseases, no PCP, nothing. Then that person is working. And second most important thing, as Daksha said, that if you can intervene at the employer level, if somebody is discriminated, I tell employer that if you employ a HIV positive person or continue to employ HIV positive person, that person is better than HIV negative person. And that I can tell with the confidence of seeing in my own clinic. I have employed one HIV positive lady for 25 years, 24 years, and she is much better than HIV negative people. I have employed a Devdasi turned sex worker turned reformed lady working with me for 35 years. She is more sincere than any other person. Other person have turned around here and there. This person has not left. So for a person who is employer, you build their confidence that employing or giving good chances to HIV positive person is not going to go waste. The person will be always grateful to you in life. And I think that kind of counseling of the worker is also required. So I think when dealing with HIV, it is not merely a mechanical that you person has come, give a tablet. You do a lot of things, and that has to be done at least for the first time. Unmute, Hitan.
The next question is for you, sir. That is, how are clinicians currently managing long-term ART related toxicities and switching regimen appropriately? How to switch regimen, how to manage toxicities?
Firstly, decide what is the culprit. When you investigate, decide what is the culprit. If you realize there is a bone problem, renal problem, remove tenofovir. If you can remove even TAF or tenofovir, both, it works, no problem. If you find that person is already lipid profiles are derailed, avoid FTC. If the person is already having a diabetic problem, then monitor more often whether your bictegravir or DTG is causing further diabetes or escalation. So I think you need to identify a culprit, and then sooner than later try to put the person on less drugs, only two regimen or two drug regimen, a single tablet. That is always better because there is more compliance and less adverse effect. Cost is also less. Somehow the cost between three drug regimen and two drug regimen is hardly 100 200 rupees difference, but cost can go down. And even during in the crisis situation in Africa, where PEPFAR has withdrawn, I think there's a great need of research by pharma companies, because nobody else will do that. How we can treat them at a lower dose of medicine and two drug regimen. So rather than three drug regimen, it can be two drug regimen. One drug goes out, cost can go down. So I think we need to look at that, because we need to sustain Africa, which has a almost two-third burden of the HIV of globally, and they were all habituated to getting everything free. So we need to also make them contribute something, at least 10% of the cost of medication. Then it we can escalate to 20%, but at least something should be contributed. So we need to look at individual level, society level, and a country level.
Okay, okay, so the next question is, with the funding to WHO being temporarily stopped, will it impact the global program? And do you see post this the LA not being incorporated in public program?
See, funding or no funding or high funding to WHO, it doesn't affect anybody. We have seen how WHO acted during the COVID. It was totally China centric. And WHO misguided people, created so much stigma, which they should not have. And COVID patients were treated worse than even HIV positive person or leprosy patients or TB patients. So I think it doesn't matter if WHO doesn't get money. WHO doesn't support anybody. Even people want to come to conference, they ask us, can you pay our ticket to travel? So I think it doesn't affect. What affects is those which are already working in the intervention program or delivery program at grassroots level. And grassroots organization need to be supported. So funding cut should not be there for the grassroots organization. All big organization can survive. They are, though we call it intergovernmental organization, they are political organizations.
Okay, okay. The next question is for you, ma'am. The question is, we salute your leadership since over 2 decades now. Please share how you took care of yourself over the years before ART era and now, ma'am. This is the question.
So that's a very good question, actually. Before 2007, I started my ART medicine in 2007, क्योंकि जब 2004-5 में ART मेडिसिन रोल आउट हुआ था पूरे स्टेप बाय स्टेप कंट्री में, तो तब एक राशन सिस्टम से मेडिसिन दिया जाता था, लाइक आपका CD4, आपका हेल्थ स्टेटस, वो सब काउंट किया जाता था. डॉक्टर गिलाडा सर ऑलरेडी नोज अबाउट दैट. तो मैं मैं लकीली उस टाइम पे उसमें उस फ्रेम में फिट नहीं हो रही थी, तो मेरा मेडिसिन उस टाइम पे स्टार्ट नहीं हुआ था. बट आई डायग्नोज इन 1998. So that 9 years journey is very important with me, क्योंकि उस टाइम पे विदाउट मेडिसिन, और जब भी हम जो भी डॉक्टर के पास हम देखते थे, पूछते थे कोई भी बीमारी है, तो हम यही पूछते हैं कि व्हाट इज द ट्रीटमेंट. तो मैंने मेरे भी डॉक्टर को जब पूछा, तो उन्होंने बताया कि दक्षा, योर मेडिसिन इज अराउंड 25,000 पर पर्सन पर मंथ. तो मैं और मेरे हस्बैंड दोनों HIV पॉजिटिव थे, तो ऑलमोस्ट more than 50,000 plus my monitoring health checkup everything. और तब medicine was not available in my city Surat, तो doctor asked me to visit every time to Mumbai. तो शायद तब रेट्रो भी नहीं बनाता होता, एआरटी मेडिसिन इतना चीप नहीं था तब। तो देन आई आस्क डॉक्टर कि इतना तो मेरा कैपेसिटी नहीं है, तो हाउ आई कैन सरवाइव, क्योंकि इम्पोर्टेंट इज कि आई शुड बी, मतलब मुझे हेल्दी रहना है। तो दोज इयर्स आई मेंटेन, पहला तो मैं मेंटली पहले स्ट्रेस फ्री के लिए मेरा सब सिस्टमाइज किया। HIV के साथ पहले तो मैंने मेरे फैमिली में ही बता दिया था कि मैं HIV पॉजिटिव, तो डिस्क्लोजर होने की वजह से मैं एकदम स्ट्रेस फ्री हो गई थी। सेकेंडली मेरा जो डे वर्क था, तो पहले पर्सनल बिजनेस था, बाद में मैं थोड़ा और एडिशनल कम्युनिटी मोबिलाइजेशन के साथ मेरा काम शुरू हुआ। एंड 2002 ऑनवर्ड्स मतलब मेरे दिन के आवर्स मुझे कम पड़ने लगे, दैट वाज द सिनारियो। तो मतलब बिजीनेस, हेल्दी लाइफस्टाइल में भी मतलब तब पानी की बोतल साथ में लेके मैं जाती थी, गर्म पानी घर पे करके, तब ये फिल्टर मशीन वो सब नहीं थे। तो दो स्मॉल स्मॉल थिंग्स बट इट सेव्ड माय लाइफ। न्यूट्रिशन पे ही हम ज्यादा फोकस करते थे, क्योंकि दवाई नहीं है तो खाना खाओ, खाना खाओ और अच्छा रहो। और फ्रॉम डे वन आई नेवर हेजिटेट कि मैंने हमेशा सेफ सेक्स किया है, मेरे हस्बैंड भी पॉजिटिव है, फिर भी मुझे एक मंत्र दिमाग में मेरे डॉक्टर के थ्रू फिट हो गया था कि मुझे हमेशा सेफ सेक्स करना है, कॉन्डोम यूज करना है। तो दैट मंत्र आई एम स्टिल फॉलोइंग। तो दैट इज माय बिफोर ART मेडिसिन इनिशिएशन, इट इज मेक मी लाइव कि मेरा जिंदगी मुझे एक पूरा जीने के लिए मुझे एक सपोर्ट सिस्टम बना। तो जब मेरी मेडिसिन इनिशिएट हुई 2007 में, आफ्टरवर्ड्स आई नेवर एवर मिस्ड माय वन डोज। और मेरा जो भी मेडिसिन ट्रीटमेंट है वो मैं ऑन टाइम लेती हूँ। इवन अभी तो इतना प्रैक्टिस मुझे हो गया है कि कोई भी कम्युनिटी मेंबर फील्ड में से जब भी हमें ऑफिस में मिलते हैं, फील्ड में जाते हैं, कोई भी कहीं पे हम एकदम न्यूली डायग्नोज पर्सन को मिलते हैं, हम पहले पूछते हैं आपके मोबाइल में अलार्म सेट है? तो बोलते हैं नहीं मैम, हम टीवी सीरियल से याद कर लेते हैं, घर में खाना खाने के बाद खा लेते हैं। तो मैं मेरा मोबाइल दिखाती हूँ कि देखिए इतने रिमाइंडर मेरे मेडिसिन के साथ मैंने सेट किए, तो मैं उनका फोन सेट कर देती हूँ। तो इतना मतलब प्रैक्टिकल लाइफ में ये सब हो गया है। द अनदर पॉइंट इज कि कभी भी कुछ चीजें नेगेटिवली नहीं लिया है, क्योंकि ऑफ कोर्स विथ HIV देर इज मेनी टाइम वी फेस सोशल और हेल्थ केयर सेटअप और एनीवेयर सम मिसअंडरस्टैंडिंग और स्टिग्मा। लेकिन उसको मैंने कभी उसको नेगेटिवली नहीं लिया है, क्योंकि मैं पहले तो यही सोचती हूँ कि उसकी नॉलेज कम है इसलिए वो मेरे साथ इस तरह का शायद बिहेवियर कर रहा है। देन स्लोली स्टार्ट कि मेरा तो काम ही ये है HIV के बारे में अवेयरनेस करना, फिर डिस्क्लोज करना, फिर उनको भी मेरे साथ जोड़ना। तो दैट इज माय अनदर लाइफ मंत्र कि उसने उसने मुझे कुछ मिसअंडरस्टैंड किया है, तो इसका मतलब ये नहीं कि मैं भी उनके साथ वही बिहेवियर करूं, बट माय रोल इज बिगर देन द अनदर पर्सन। तो अभी इतना हेल्थ कॉन्शियस हो गए हैं, न्यूट्रिशन डाइट इतने फॉलो कर रहे हैं, और ट्रीटमेंट इज अवर मेन पिलर ऑफ अवर लाइफ। सो दैट्स व्हाई वी आर हेल्दी एंड टुडे joining this call as a long-term survivor.
Thank you so much, ma'am. Thank you. The next question is for Sir, ma'am. Sir, what are the effects of constantly activated immune system, and does this has any effect on accelerated aging?
No, no. Immune system, if you look at, we have a double immune system, then it is required. We have a lot of things are double. Two eyes are there, 2 ears are there, two nostrils are there, two brain hemispheres are there, two testicles are there, two ovaries are there. So we always have a double immunity. It doesn't mean that all double immunity works. Our immunity is most intelligent, much more intelligent than any Indian or Pakistan or any army. They know how to trigger and how to stop. And in our immunity, there's a CD4 cell, there's a CD8 cell. And a lot of people do not understand the mechanism of CD4, CD8. So I would like to tell your viewers in a very simple term, when you drive vehicle, you have an accelerator and you have a brake. So if there is no brake in the vehicle, accelerator will keep on accelerating and you will make accident. And if brake is there, then you will say, okay, you accelerated to some level, then you put a brake. Your speed breaker has come, somebody has come, a vehicle has come, or a signal has come, you brake. And that CD4, CD8 mechanism always goes on as a balancing act. Therefore, whatever your immunity is activated, it is activating both CD4 and CD8. So it is acceleration that the example is that our mind is shaped in this way that somebody comes and slaps that person. That person will slap him one or two, double. But that person will not murder that person, that he has slapped me, so I will murder. So whenever we see उसने थप्पड़ मारा, उसने उसका murder कर दिया, is aberration. That can happen, but this is aberration. In routine sense, it doesn't happen. So our body's immunity is acting in a very, very methodical manner. So whether you escalate immunity through medicine, whether escalate through counseling, it will both the CD4, CD8 are escalated and both are having tending to each other. When you are not on treatment, when immunity has gone down, CD4 is low, CD8 is high. It's only break, there is no acceleration. And therefore, your body cannot make antibodies. And when you cannot make antibodies, then a simple infection, for example, 10 people are sitting, one person is a low immunity, 100 CD4 count, and a TB person comes and coughs. Everybody is breathing the same air, but the person with the low CD4 can pick up TB, and TB can act in that person, and other people can digest TB and it will not act. So digestion is also called phagocytosis. Phagocytosis is a mechanism by which we eat the foreign cells, foreign infection, foreign organism. So even if we get infection every day through food, water, air, every infective organism doesn't give us infection. We can digest. And therefore, that modulated immunity, despite having a treatment, it remains good, except iris, immune reconstitution inflammatory syndrome. In iris, sudden immunity up, and then we always tell people that tuberculosis is like दुख में भी आंख में आंसू है और सुख में भी आंख में आंसू है. तो टीबी कैन कम इन गुड इम्यूनिटी, टीबी कैन कम इन बैड इम्यूनिटी. बट आंख में आंसू तो आंसू है, पूछना तो पड़ेगा आपको. And therefore, when there is iris, there can be TB, there can be syphilis, there can be other infections which are cryptococcal meningitis, which are in lying down condition, go up, PCP. So all this can come up. So except iris, all other times immunity can go up and person can live very healthily. It doesn't affect that it is going to create any problem in that person.
Okay, sir. Okay. There is one more question for you, sir. Is HIV DNA test is the only gold standard for earliest diagnosis of HIV?
See, gold standards are now also antigen antibody test or dual test, where within 3 to 6 weeks that test become positive, and that is cheaper and that can be done in a room or in a clinic or anywhere. But when you talk about establishing a diagnosis, the DNA PCR or RNA PCR, viral load, both are important and that can diagnose. But nowadays, DNA PCR is hardly done anywhere. So whenever you do PCR also, that can show it is RNA, and whether it is less than 40, less than 34, less than 50, whatever company you are using it. And less than 40 can be 39, that can be 1. And target not detected is 0. So what happens is, if you base your diagnosis only on PCR, then even if you are elite controller, it will be positive, but you are not doing antibody, so you will not know whether it is positive or not. And that test will show negative. And you will be always in a false paradise that you are negative, but you are still positive. So we need to do antigen antibody test. We need to do this test, and both the tests should decide what is the importance of one another at a particular time of interval.
The next question is for ma'am. So basically, what are some of the most harmful myths and misconceptions about people living with HIV, and they are still prevalent today. So, what are the communications should be followed to reduce all this? So, what are the myths and misconceptions?
ओके सो अभी भी जैसे एक टेबू है HIV के बारे में, और काफी ऐसे वर्ड्स यूज किए जा रहे हैं, या फिर ऐसा एक एज्यूम किया जा रहा है कि मेरा अगर जब भी HIV स्टेटस की बात आती है तो मेरे कैरेक्टर के साथ इसको जोड़ दिया जाता है, या फिर ऐसे क्वेश्चंस पूछे जाते हैं कि अभी भी जैसे टेस्टिंग के लिए भी हम जब बात कर जाते हैं तो वहां पे भी ऐसे क्वेश्चंस वहां पे आते हैं कि आपका किसी के साथ सेक्सुअल रिलेशन है, या तो वो बहुत पर्सनलाइज चीजों की वजह से लोग ओपनली बात नहीं कर पाते हैं. सो those questions are sometimes not comfortable for anyone. और वो भी एक पहले स्टेज पे, और वो एक स्टिग्मा लीड करते हैं, क्योंकि हमें ये भी पता चलना चाहिए कि दिस इज अगर किसी को HIV लग रहा है तो वो सिर्फ एक ही रीजन नहीं है, देर इज अदर 4 रीजन ऑल्सो. तो वो चारों रीजन के बारे में भी मालूमात होना, अवेयरनेस होना बहुत ही इम्पोर्टेंट है. तो क्वेश्चंस which is only leading to my sexual behavior, that is sometime or many people are hesitate to open their HIV status or accept their HIV status to any setup.
Okay, ma'am. Okay, thank you. So the next question is about the vaccination, which you have covered actually. So how does HIV infection affect the immune response to commonly recommended vaccines? So this is the question.
See, basically, if you have done the CD4 test in the beginning, when the patient has come, and if the CD4 counts are more than 200, more than 300, then all vaccines can work at that time. When immunity is very low, less than 50, less than 100, less than 200, at that time we can avoid some of the vaccines which can be at a later date. Number two, hepatitis B vaccine can be given even at a very low immunity also. And number three, some vaccines are expensive, some are cheap. So at least cheap vaccines, which are like hepatitis B or typhoid, can be given to everybody, whether person is affording or not affording, because they are very cheap vaccine, and that will also prevent some of the infections. And I would like to also add one point in what you asked, Daksha. A lot of myths and misconceptions, not in common people, it is in medical community. Most of the surgical people, while doing surgery, they will say HIV positive person last on the list. Why last on the list? HIV positive person, when even despite sending a person that he is HIV positive, they still do HIV test. Why? This is a hospital policy. What nonsense hospital policy? If I am hiding the diagnosis of the HIV positive person, then you do. But when I'm saying a person is HIV positive, after doing HIV positive, then they say, no, no, then we have to check viral load. Some surgeons are wise. They ask, what is the viral load? If viral load is suppressed, if CD4 counts are good, we'll go ahead with the surgery. Same problem with obstetric and gynecologist. They are taking extra charges for delivery of HIV positive person. The problem in this country is, Daksha madam, you need to really revitalize your community. They need to fight. They need to file cases. Despite being a doctor, I say you file cases against doctors, against hospitals who are discriminating. On different ways, they write on case paper, HIV positive, seropositive, isolation. Why you need to write? Do you write diabetes? Do you write hepatitis B? Do you write anything else? If you want to write, you write hepatitis B. It's 100 times more transmissible than HIV. But you don't do that. And so therefore the whole problem is higher the education, more the discrimination. Lower the education, less discrimination. When we see in our clinic, uneducated people coming from village area, very much illiterate, they are very supportive. And highly educated person comes in the cabin, and as soon as patient goes out, sir, मुझे तो कुछ डर नहीं ना, मेरे बच्चे को कभी वो किस करता है उसको तो कुछ नहीं होगा ना. So they are highly suspicious, they are highly educated, despite that they are having myth and misconception. So I think a great job need to be done around U is equal to U, hugging patient, asking them to sit together, eat in the same plate, nothing happens. And this we demonstrated almost 25, 30 years back. Yeah, go ahead, Heather. Unmute.
Extremely sorry, sir. Can hospital charge extra money for surgery of PLHIV? If yes, how can it be tackled?
No hospital should charge extra. I always tell people that if your fees is 10,000, you make 20,000 for everybody, no problem. But if you charge 1,000 rupees extra for being HIV positive, this is wrong. And in such cases, I tell my patient, go with a mobile clinic, a mobile record and file cases. But nobody files cases. That is a problem. So any money extra, whether for the bed or for surgery or for any procedure, I'm asking my doctor colleagues, how is your risk reduced by charging extra? You tell me. If you think there is a risk, how your risk is reduced by charging double money or extra money. So this is all wrong, and there is a wrong way of making money. And lastly, all the hospitals doing HIV test, you go to all, even charitable hospital, they call public charitable hospital. And what is a triple H charge? 2,000, 3,000 rupees. The material cost is just 200, 300 rupees for 3 tests. You charge 1,000 rupees fine for every, and suppose the surgery is not done at that time because of some reason, patient come back after 4 weeks, again test is done. So you inflate the charges for HIV negative as well as HIV positive just to make that quick buck, and that should be stopped.
I just want to add here, Hetal. I want to share my personal experience in this regard. When I diagnosed on that time, I went to one gynecologist for my, because when I diagnosed on that time, treatment is like a dream, and I have not received any perfect message or प्रिवेंशन मैसेज कि मैं मेरे बच्चे को किस तरह से HIV से बचा सकती हूँ। तो मुझे जितने भी मैंने डॉक्टर्स को कंसल्ट किया, मुझे यही पता चला कि मेरे HIV, मेरा बीमारी HIV की जो है वो मेरे बच्चे को लग सकती है। तो उस टाइम पे फिर मैंने और मेरे हस्बैंड ने डिसाइड किया कि हम एबॉर्शन करवाएंगे। तो जब मैं एबॉर्शन के लिए गई उस टाइम पे तो सिर्फ 1,500 या 1,000 रुपए एबॉर्शन के होते थे। You cannot believe my doctor in gynecologist private hospital, they asked me 16,000. तो मैं थोड़ा सरप्राइज भी हो गई कि ये 16,000 रुपए, क्योंकि तभी से ये सब जो बोलते ना कि एक्टिविज्म तभी से दिमाग में शुरू हो गया कि 16,000 मीन्स नॉट स्मॉल अमाउंट इन दैट पीरियड बिफोर 22 years 23 years बिफोर। तो आई आस्क डॉक्टर कि क्यों इतना चार्ज है। तो एग्जैक्टली डॉक्टर गिलाडा जैसे बता रहे हैं अभी कि उन्होंने मुझे बताया कि जो भी आपके ऊपर हम शस्त्र और जो आपके बेड और जो भी है वो सब हमें थ्रो आउट करने पड़ेंगे। सो दैट मिसकंसेप्शन इन इन डॉक्टर। तो तब मेरे पास इतना नॉलेज नहीं था, इंफॉर्मेशन नहीं थी, वरना तो मैं डेफिनेटली केस फाइल कर देती डॉक्टर। लेकिन मैंने इतना उनके सामने जरूर बोला कि ये जितने भी इंस्ट्रूमेंट्स आप मेरे पे यूज कर रहे हो और आप बोल रहे हो कि उसको आप थ्रो आउट करोगे, फेंक दोगे, तो इससे अच्छा है कि उसका बैग भर के मुझे दे दो, मैं मेरे शोकेस में घर पे लगाऊंगी, मुझे ऐसा लगेगा मैंने कुछ शॉपिंग किया है। That was message I given, and still today exactly the challenge is about when any individual community member are charged extra on that time, the problem is we are with them कि आप फाइल करो केस, हम आपके साथ है, हम आपको जो भी एम्बेसमेंट ऑफिसर या जो भी सिस्टम है उनके साथ आपको कनेक्ट रखेंगे। लेकिन लोग अपना केस फाइल करने के लिए डरते हैं बिकॉज ऑफ सेल्फ एक्सेप्टेंस, स्टिग्मा सराउंडिंग देम। उनको ऐसा अभी भी ऐसा महसूस होता है कि मैं अगर ये सब कोर्ट कचहरी में या मैं अगर केस फाइल करता हूँ या करती हूँ तो माइट बी आई मेरा HIV स्टेटस डिस्क्लोज हो जाएगा, क्योंकि उनके घर में किसी को पता नहीं होता।
Right, ma'am. Ma'am, there is one more question which has come up. So how you're mobilizing people with HIV to go for vaccination they are eligible for, including HPV vaccine for younger people and cervical cancer regular screening for all the eligible ones. Can you share your experience, which is critical to fill the gap between NCD and HIV programs?
You are absolutely right. Uh, just recently in last month on same day, same date, 5th, we had a very national dialogue and consultation with all women living with HIV about cervical cancers and aging issue. उसमें लाउडली मतलब जो चैलेंजेस और इश्यूज निकल के जो आए कि देर आर वेरी वेरी इंपॉर्टेंट टू मेक वन ऑफ द अवेयरनेस जो एक अगर अर्ली डायग्नोज किसी का हो रहा है वुमेन का सर्वाइकल कैंसर ब्रेस्ट कैंसर या ओरल कैंसर के लिए तो डेफिनेटली वो ट्रीटेबल है और वो अर्ली स्टेज में हम उसको प्रिवेंट कर सकते हैं लेकिन वो इंफॉर्मेशन जो वुमेन के अंदर है नहीं है या वो अवेयरनेस हमें लेके आने के लिए हम छोटे छोटे सपोर्ट ग्रुप मीटिंग अभी हमने शुरू किए हैं वेबिनार्स हम प्लान करना शुरू कर दिया है लास्ट सैटरडे हमने मेंस्ट्रुअल हाइजीन के ऊपर भी हमने वेबिनार किए मेनली उनके जो हेजिटेशंस है क्योंकि जब गायनेक डिपार्टमेंट में जाते हैं वहां पे मेल डॉक्टर है तो उनके जो वो हेजिटेशन है उनको पता नहीं कि ये अगर मेरा डायग्नोज होता है तो उसके बाद ट्रीटमेंट भी अवेलेबल है तो ईच एंड एवरी लेयर पे जो उनको इन्फॉर्मेशन देना है that role being a community network CBO we are playing in our within community member अभी जैसे 8 मार्च से हमने पूरा एक कैंप सिस्टम एंड अवेयरनेस कैंपेन शुरू किया था तो कुछ स्टेट के ऐसे डेटा भी हमारे सामने आए कि उसमें कैंप में जैसे 1 वीक कैंप हमने किया था सर्वाइकल कैंसर के लिए स्क्रीनिंग के लिए उसमें 10% 20% तक वुमेन ड्रॉप आउट भी हो गए जैसे कि कैंप के बाद वो स्क्रीनिंग के लिए नहीं आए रेफरल होने के बावजूद भी और उसमें डायग्नोज भी हुए सर्वाइकल कैंसर सस्पेक्टेड केस में फिर उनका कंफर्मेटरी टेस्ट किया अभी उनकी हमने इमीडिएट ट्रीटमेंट तक भी शुरू करवा दी है सो दैट लेवल ऑफ हैंडहोल्ड वी आर विद देम लेकिन मेरे हेल्थ के लिए मुझे एक स्टेप आगे आना पड़ेगा तभी मेरे लिए पूरी दुनिया वहां पे खड़ी है
True, ma'am. That's very true. Sir, there is one question that can you just explain PrEP and PEP in a very simplified manner for the patients who must have joined today?
See, PrEP is a pre-exposure prophylaxis यानी आप एक्सपोज होने के पहले दवाई खाते हो और PEP यानी पोस्ट एक्सपोजर प्रोफिलैक्सिस वो एक्सपोज होने के बाद खाते हो ये दोनों चीजें नई नहीं है ये बहुत पहले से है HIV में वो फेमस हो गई जैसा पहले सिफिलिस में भी था एक्सपोजर करके आए तो लोग पेनिसिलिन का इंजेक्शन लेते थे इमीडिएटली और प्रिवेंट करते थे टीबी में हम लोग प्री एक्सपोजर प्रोफिलैक्सिस देते थे घर में एक टीबी का केस है तो दूसरे को बचाने के लिए देते थे तो ये कई चीजें पहले से थी लेप्रेसी में थी अब ये HIV में पॉपुलर हो गई प्री एक्सपोजर प्रोफिलैक्सिस एक है कि इसमें 2 मेडिसिन का कॉम्बिनेशन होता है टेनोफोविर एंड एम्प्टीसिटामिन और मेल के लिए टैफ और एम्प्टीसिटामिन भी चलता है तो ये दोनों का गोली का लेने से इसमें 2 नमूना है एक तो डेली खाओ अगर आपकी रिस्क डेली है हफ्ते में 1 बार 2 बार 3 बार भी है तो आप डेली खाओ अगर आपकी रिस्क महीने में 1 आध 2 बार है तो इट इज कॉल्ड इवेंट बेस्ड प्रेप 2 गोली 12 घंटे पहले एक गोली प्रेप इवेंट के समय और 1 गोली 12 घंटे बाद तो पर इवेंट यू नीड 4 टैबलेट तो जैसे इसका प्रेप है उसी ढंग से दूसरे बीमारी का भी प्रेप है पीपी जो है अगर आप एक्सपोज हो गए हैं और अगर आपका एक्सपोजर HIV पॉजिटिव को है या हाई रिस्क बिहेवियर को है या अननोन पर्सन के साथ है या सेक्स वर्कर के साथ है या हिजरा कम्युनिटी के साथ है जहाँ पे चांसेस ऑफ HIV ज्यादा है देन यू नीड 3 ड्रग मेडिसिन विच इज आइदर bictegravir based regimen or DTG based regimen with other 2 backbone. If the exposure is low where you use condom फट गया कि नहीं मालूम नहीं या आपका दिमाग थोड़ा ऐसा लग रहा है कि मुझे हो गया तो क्या है then 2 drug regimen will work which is the same which is PrEP or PEP. The person who is on PrEP and exposed he doesn't have to take PEP क्योंकि वो ऑलरेडी PrEP पे है कई बार वो हो जाता है और इसी ढंग से एक डॉक्सी पेप है जो एक्सपोजर के 48 आवर के अंदर लेने से एक ही बार खाना है, 2 tablets or 2 capsules of doxycycline, which will prevent 70% of syphilis, 70% of chances of chlamydia, and 50% chances of gonorrhea. One single dose of 2 tablets, which is costing just 2 rupees or 5 rupees, that can prevent 3 infection by 70% chances. Similarly, if you are exposed and you have not been vaccinated against hepatitis B, PEP is also there, which is called rapid immunization. You take 1 dose immediately within a day or two, 1 dose after 7 days, 1 dose after 21 days, and 1 dose after 1 year. So rather than 3 doses, you are taking 4 doses, but that prevents you also from last exposure. So these are the PrEP and PEP. Unmute, please. Unmute.
If there's this last question, sir, if the patient has HIV TB co-infection, how to really start treating that patient, and what all are the monitoring, how the treatment is going to start?
So basically, we talk about more people which are with HIV and TB, and less people where we need to wait. More people with HIV and TB together, and if CD4 count is good, if patient is otherwise healthy, we always say HIV treatment is not an emergency. So you can postpone starting HIV treatment by at least 2 weeks. And that's a guideline that if TB is there, you start TB treatment. After 14 days, you can start ART treatment. But if the immunity is very low, if the person is having multiple other diseases, and you need to treat HIV as well as TB, we can start together. But always keep in mind that iris can be there, because when you start ART on a very low CD4 count, then iris can be there. So we need to watch more often, and we sometimes need to give a cover of a steroid. And steroid is not very high dose, but a small dose. So in TB, we can treat together, we can wait for 2 weeks. If there is a chances of brain TB, then you need to wait for minimum 6 weeks. At least 4 weeks to must have, but 4 to 6 weeks. And same thing is applied to the cryptococcal brain infection. You need to wait for 6 weeks.
Okay. Okay, so just wanting you to share your last message for the session today.
Now, my message is to 3 people. To the HIV positive people, you need to have activism. You understand that we fought 30 years to get that HIV/AIDS Act 2017. My blood boils because there is not a single case. And sometimes I feel कि मैं पागल हूँ, 30 साल से लड़ रहा हूँ इसके लिए. Not a single case. It doesn't mean that they are not discriminated. Discrimination is at clinic level, hospital level. Second important thing for them, that you don't need to give your name. There is a High Court of Bombay ruling which is applicable all over the country, that a PL-HIV can fight case as Mr. XY, Miss XY. You don't need to disclose. And number 3, if you are scared that somebody will make it public, then that is again case against that person for knowingly making public that you are HIV positive. My message to the doctors community: undetectable is untransmittable. Your patient with HIV under treatment is better than non-HIV. But non-HIV, you do not know whether the person is in window period, whether the person could have had multi-partner sex couple of days before, which is very common, and that person is infecting you, and you think that you are operating HIV negative person. HIV positive person on treatment, undetectable is untransmittable. If that person doesn't transmit infection to his wife or child, how will that person transmit to you without you having sex with that person? Even if you have sex, you do not get. And my message to the government: please start PrEP free of charge. If you are giving PEP free of charge, if you are giving treatment free of charge, there is no point in not giving PrEP free of charge. Please allow HIV self-test at home. You can get HIV self-test through Amazon, but it is not in program. So I think these are some of the things which we need to go ahead. They are all small countries which are much hardship countries than India. They are practicing and we are not practicing. We need to achieve that 95, 95, 95 definitely, because very poor countries, based on somebody's arms and support, they are achieving 95, 95, 95 much earlier than us. We are not achieving. That is not acceptable. Thank you.
Okay, so Daksha ma'am, again, I would like you to share the last message to the person who is newly diagnosed, or the person who is who wants to actively involved in the activities for fight against HIV?
So, हेतल, थैंक यू। ये बहुत ही इम्पोर्टेंट है कि अभी जो न्यूली डायग्नोज हो रहे हैं उनको मेरा एक यही मैसेज है कि जो ट्रीटमेंट है दैट इज अ फ्री, बट इट नॉट मीन कि वी आर नॉट टेक रिस्पॉन्सिबिलिटी। अभी if you are initiating your medicine, so first off you understand about importance of that medicine. Treatment preparedness is a very important, and treatment adherence is a more important. So that's a thing each and every community member who are initiating ART medicine that must be keep in their mind and in their life, to how to take medicine for lifelong. The secondly about अगर हम बोलते हैं कि HIV फैल रहा है, तो HIV फैलने के लिए एक HIV पर्सन जरूरी है। तो वाई आई विल नॉट टेक अ सोशल रिस्पॉन्सिबिलिटी टू स्टॉप HIV वायरस टिल टू मी ओनली। मतलब मैं HIV प्रिवेंशन का एक बहुत बड़ा माध्यम हूँ, तो आई शुड टेक रिस्पॉन्सिबिलिटी बीइंग अ HIV पॉजिटिव पर्सन to make a positive prevention of HIV. And the third thing is about connect with the social or any HIV positive community network, or many other CBOs are there who are working with the MSM, transgender, sex workers, even people in HIV. So be connect and be informed. गूगल बाबा की जरूरत नहीं है, लोग ऑलरेडी काफी अभी वेल ट्रेन्ड, वेल एक्सेसिबल है कि जहाँ पे आप इंफॉर्मेशन करेक्ट एंड प्रॉपर इंफॉर्मेशन ले सकते हो। क्योंकि कभी कभी सोशल मीडिया is not giving correct answer or correct information, it might be misguiding to you also. And HIV act is for you, तो उसको एक्सेस करने के लिए आपको आगे आना पड़ेगा if you are facing any stigma. So this is my last message to all newly diagnosed with HIV, and be healthy and be long life with HIV.
Okay, thank you so much. I'll just have a last word for everyone. Good evening, everyone. As we conclude today's enlightening session and deeply engaging webinar on managing long-term survivors of HIV, medical and social challenges, I take this opportunity as a part of Medical Affairs team and thank you each and every one of you for your valuable time and participation. First and foremost, I would like to extend my heartfelt gratitude to our esteemed speakers, Dr. Gilada sir and Daksha Patel ma'am. Thank you for sharing your clinical insights and experience in managing long-term survivors of HIV and shedding light on how the treatment has evolved over the time, over the decades, how to manage comorbidities and patient-centric approach. Your contribution was truly enriching. A special thank you to all those who have joined us today uh, after their busy schedule, and to all the healthcare professionals and participants who has joined us today across the country. And thank you for your active engagement, for your thoughtful questions and your ongoing commitment to the care of people who are living with HIV. At the end, I would like to thank on the behalf of Healthcare, on the behalf of our Senior Vice President, Mr. Nehru Dadi Sethi, from our marketing team, Mr. Vijay Thorat, from our sales team, Mr. Gajendra Yadav, and from our informational technology team, the IT team. Without support from them, this event wouldn't have been possible. So thank you each and everyone. And let's continue to work together to ensure that people living with HIV not only survive, but they thrive. So thank you once again and looking forward to stay connected. Thank you all. Good night. Stay connected. Thank you.
Now I have to thank my battery, which worked till the end. Now it is saying battery status is going 18%.
I was about to ask you that, sir.